Well, thank you very much for having me here today in Lausanne, a beautiful day. Thank you for inviting me to the conference, to Federico and the whole ALPS team. Today I want to talk about the standardization of ketamine-assisted psychotherapy and doing so with our therapy concept at the OVID clinic in Berlin. As Abigail already mentioned, my name is Sergio Perez. I'm a medical doctor specialized in anesthesia, intensive care, and emergencies. So if you kind of get tired throughout the presentation, it's just part of the job description. I'm also the Mind Academy director, where we have created programs for academics and the general public to, get a proper education, which I found lacking in my own medical training. And I am the medical co-director of the OVID clinics and OVID health systems. Together with my colleague, Dr. Andrea Jugabele, and Professor Dr. Gerhard Gründer, we have opened in February the first psychedelic augmented psychotherapy clinic in Berlin. And yes, you already heard we're using ketamine, and we are not alone. Again, I'm an anesthesiologist, Andrea Jungabele also, but we have the help from Professor Gerhard Gründer, which is the PI in the second biggest study using psilocybin for treatment-resistant depression in Mannheim and the University of Charité, with 144 participants altogether. We have a group of highly specialized psychotherapists from the cognitive behavioral schools as well as psychoanalytic schools. And of course, we wouldn't be able to work without the help of our clinic manager and medical team managers. Now, we have created a clinic with a concept of being as less hospital and clinic looking as we could without voiding the rules that there are to have this kind of setting. So our clinic and our setting, as you see, is different than most of the hospitals and resembles more that of the psychedelic centers at Johns Hopkins or at Imperial College. Now, ketamine therapy or ketamine treatment isn't nothing new, but the way that we are using ketamine is. We are not using ketamine as a pharmacon alone, but are implementing it in a psychotherapeutic approach. Therefore, we call it ketamine-augmented psychotherapy. As I already mentioned yesterday, we think that any kind of psychedelic therapy is, at the end, psychotherapy. So we treat ketamine as an atypical psychedelic and base our approach on not only the pharmacology, but also on what we know about the psychedelic experience and about integration therapy. Now, let me show you how a standard patient would go through our therapy concept. We have this nice slide, nice presentation for you to take an idea on how the typical patient would go through our examinations. Up front, we don't take every patient. We have a psychiatric and anesthesiological examination to assess the feasibility, which we often do together and after each other, so that we actually see the indication from the psychiatrist and the bodily checkup so that they can really get ketamine without any health problems or counterindications. After that, we have 2 sessions of psychoeducation, so the patients can learn more about altered states of consciousness. This can be done online, this can be done on-site, and also as a group. Afterwards, in the first session, is not a session with ketamine, but we create a preparatory session with the psychotherapist that we couple the patient with, so that they get to know each other. Remember the Klaus Grabe's principles of psychotherapy? One of those, and the most important one, was the therapeutic alliance. So you have to build a relationship with your therapist and clarify the problem and your goals, your intention. And then we provide a session with an altered state of consciousness, but not with a substance, but a non-pharmacological method. For example, the stroboscopic light, called Lucia number 3, has some properties that resemble a lot the state of a psychedelic experience. So this is for people to be prepared for the treatment with ketamine, which can be sometimes for patients without any experience in altered states of consciousness, very disruptive and troubling. Over the period of 5 weeks, we provide 1 day a ketamine session, which is always guided and accompanied by a psychotherapist, and for the first session, anesthesiologist. They have a monitoring, an ECG, blood pressure, and pulse oximetry, measuring the oxygen levels in the blood, so that we have this full monitoring that you would encounter in an OR and on an operating room under surgery, to provide the safety objectively and subjectively to the patient. Ketamine is given IV at our clinic. There are different methods of application. You can give ketamine orally. You can give it intravenously and intramuscularly. But we have decided that the best approach, at least in our eyes, is to have full control over how much and over what period of time we are giving this substance. So we adapt individually to body weight and metabolism the necessary dose, and provide it with a syringe pump called a perfusor. And the day afterwards, we meet with the patients again, or the psychotherapist in the clinic do, and talk about what happened, talk about what they experienced in this altered state of consciousness, in this psychedelic state. This doesn't mean that the patients don't get any kind of guidance right after the session. They have enough time, and this is something that is lacking in some of the clinics out there using ketamine just as a pharmacon, to land back at this state of consciousness and talk about these first impressions. But we do think that the first night, the first settling down of the experiences, helps the people to get more in contact to what could this mean. So therefore, we do the integration therapy the day after. We do this over a period of 5 weeks. Most of the time with us 7 days apart from each other, because if you know the data, if you know about ketamine, there is a pharmacological effect that lasts about and around 7 days. So that we keep this window of change open for whole 5 weeks, guiding and accompanying people through psychotherapy to to create something that is long-lasting, that the people come in this window of opportunity to use this vehicle, that is the substance, that is the psychedelic experience, to go further in their own journey. We don't want, and this is not our idea, that patients come again and again and again after this concept and this therapy is closed. What happens afterwards? There is one closing session, and of course there are people that will need further therapy sessions, but not with a substance, not necessarily. Most of them will need additional integration therapy sessions, which are possible, and we are always open if people are looking for that. And this is part of our aftercare program and process. After 4 weeks, as you see there, and 6 months, we have follow-ups where we visit and revisit the psychometry, the MADRS and the HAM-Ds, and see how the depressive symptoms have developed. And up until now, we have had very good experiences with people in the follow-ups after 6 months that do not resemble the same results that you get when you are just administering a pharmacon without psychotherapy. Now, for those of you that are not informed about the pharmacology of the substance, I want to just touch a couple of points there. What is ketamine? What are the risks of implementation? Why is it called as a dissociative? And can it really induce a psychedelic experience. So ketamine is a derivative from phencyclidine, better known as PCP or angel dust. It was first discovered in 1926 in Göttingen. And it was synthesized afterwards as a pharmacon, as a medicine, by Park Davis, today Novartis, in 1956. The British Journal of Anesthesia called this substance undoubtedly the most potent general anesthetic. But if you take a look at the small letters, the side effects were so high that they decided this is not for humans. It was later on that in 1962, Professor Calvin Stevens came up with this derivative of PCP. This is the molecule. It has a ketone. It has an amine. There you have it, ketamine. The neuropharmacological effects of this are mostly on the glutamatergic neurotransmission, antagonizing the NMDA receptor, also modulating the AMPA receptors, and it also has a function in the opioid receptors. Now, ketamine is one of these substances that are enantiomers. Enantiomers are this idea of when you synthesize the substance, you come up with a 50% of one-sided molecule, and the other 50% are the other-sided molecule. This is called the R-ketamine and the S-ketamine. One turns to the right, one turns to the left. Yeah, you could imagine that these look like mirror images of each other. And if you take a look at your hands, you can see that they are mirror images. They look the same, but at the end, they aren't. And they do induce a little bit of different effects if you isolate the R-ketamine or the S-ketamine. Why am I mentioning this? This is so much chemistry. Yeah, well, the interest in the pharmaceutical companies is big in isolating and creating new patents. And that's where Spravato comes from, isolating this substance that we know that works and creating an indication and a delivery system that takes out most of the psychotherapeutic approach, the psychotherapeutic guidance and company. What they don't always say is what you see here, that this is only indicated if you have a conjunction with an oral antidepressant to treat treatment-resistant depression and depressive symptoms and MDD, major depressive disorders. What does this mean? This is, for me personally, a substitution with just another pharmacon to see if this works. And it does for some. It can be the right decision, it can be the right approach. But I do believe that we will have longer-lasting effects and a better embedding effect in embedding this substance in psychotherapy. Now, why is it called a dissociative? And if you take a look at the literature and at the neuropharmacology behind it, it is a functional and electrophysiological dissociation between thalamoneocortical and limbic systems. Yes. Now, we have heard a lot about the thalamus and its role throughout this conference from Katrin Prella and Andrea Lupi. And you can imagine it like this. The thalamus is the gate to consciousness. It regulates which sensory input gets to the neocortex and is consciously accessed. One example of doing this is when you enter a room that has been painted freshly, then you smell this smell of the fresh paint, and it's not that pleasant. But the longer you stay in that room, the less and less you experience that, because it is not relevant anymore for your conscious experience. So that is the kind of the gate to consciousness that you have with the thalamoneocortical and the limbic system. Now, ketamine works as an anesthetic because it blocks the thalamus from giving any kind of signal up to the neocortex. That's why it's so good at keeping pain from arriving at consciousness. But while they were investigating this substance, while they were giving it to prisoners, as it was usual in that time, The subjects were experiencing and reporting experiences of floating on the universe, of disconnectedness. Someone even called it a psychophrenomimetic, which is, as some psychedelics have been described before, a psychotic-mimetic is not that far away from each other. Others said that they felt like they were dreaming. And John C. Lilly said it was a peeping Tom at the keyhole of eternity. Now, this seems a lot like a psychedelic experience to me. Now, coming to the hard facts and how brain-derived neurotropic factor and the response of ketamine are correlated. We have heard before also that BDNF might be a marker to the neurogenesis, and something that correlates when you give ketamine and do the psychometry with a MADRS score and see that the ketamine responders had also an increase on BDNF levels. Is it effective treating major depression? This is a review that shows you several of the studies, and on this, if the results are on this side, they favor ketamine, and on this side, they would favor the control. As you can see, it is very clear that ketamine does have an effect, at least in depression disorder. Risks. Is it neurotoxic? Well, yes and no. Under usual anesthetic practice, and we do this a lot, ketamine does not induce neurotoxicity. But when you abuse it in a recreative chronic use, then you do have reports and studies that show frontal white matter abnormalities. And it might have a potential toxic effect in the developing brain. On the physiological effects, it is a very good anesthetic because, very safe one, because it doesn't do respiratory depression other than opioids do. So it's one of those pain medications that don't take your breath away. On the cardiovascular level, normally anesthetics would induce hypotension and low heart rate levels. This is contrary in ketamine. Ketamine induces increase in noradrenaline. But recreational use, too much, is never good. When people start using it recreatively, it can lead to ketamine neuropathy. Ketamine neuropathy is not that easy to treat when you find someone coming into your ER that is urinating blood and is in extreme pain. There is not that much that you can do pain-wise because, well, yeah, they have tried that themselves. Sometimes the only thing that you can do is a spinal anesthesia to get them out of their pain. On the psychological effects, other than with serotonergic substances, there are 0 cases of psychosis after ketamine use documented. But there is a substance use disorder danger there because it has a higher addictive potential than serotonergic substances. And this can lead to a pathological use profile. So much to the pharmacology of ketamine. Now, can ketamine induce a psychedelic experience? How do we define that? How do we measure that? And we do this by using the same rules that we have given ourselves to define the other psychedelic experiences, using the mystical experience questionnaire, MEQ30, or the 5D ASC, the 5 dimensions of altered states of consciousness. Psychedelic, meaning mind manifesting, of course. Even better, using the 11 dimensions of altered states of consciousness, the 11D ASC psychometric questionnaire, to try to objectify or quantify subjective experience. And as you see here, you can see things like experience of unity, but complex imagery, anxiety, Disembodiment, dissociation, I don't know, audiovisual synesthesia, or a blissful state. So those are all things that I've heard reported from our patients. But don't take my word for that. Take the data that we have from other studies comparing the substances using these batteries of questionnaires. And if you see here, there's this presentation of the 11 dimensions of altered states of consciousness comparing LSD, psilocybin, MDMA, and ketamine. And if you follow the ketamine line, it is not quite there as other serotonergic substances, but pretty much in the same corner. Going from psychometry, subjective experience, to pharmacology, the ones that were here at the film yesterday saw that there is a glutamatergic reaction that creates an increase of BDNF after psilocybin or LSD or DMT ingestion. So what does ketamine do? Pretty much the same, but from another neuronal pathway, releasing glutamate and increasing BDNF from another side with another technique, just so to say. And if we take a look then at brain activity patterns in the psychedelic-induced states of consciousness, again, it's not the same, but it's quite in the same areas. And now, after I saw the presentation from today in the morning, I have another pretty picture to present to you next time. So to keep things a little bit shorter, I'm going to leave this very short. There are 3 principles that we think play a role in integration. The first one is remembering, which can be difficult if you don't dose the substance well, because in ketamine, when you increase the dosage, you don't get better results, you just get anesthesia. Then expressing, connecting, expressing what you remembered, making sense of what you experienced, and then connecting that to biographical patterns or introception or memories that you have that might help you change the way that you see yourself and your environment. And I'm not talking about doing so within a substance experience, but in an everyday basis. Now, these are the columns where our concept lives, and it all goes under the roof of a psychotherapeutic concept. Okay, but is ketamine a psychedelic? In 1998, there was some anesthesiologist out there talking about psychedelic effects of ketamine in healthy volunteers. Later, Yevgeny Krupitsky did some research about ketamine against addiction. Ketamine psychedelic therapy is the name that he gave it. And nowadays, in June 2018, even psychiatrists are revisiting this hallucinogenic potential of ketamine. Now, if we use the self-given rules of how we categorize substances, taking the neurobiology is the most reasonable one, because we can see that there is a thalamocortical dissociation, there is a glutamatergic system modulation, and the NMDA receptor, the AMPA receptor, even opioid, and also serotonin over different pathways are modulated. So yes, ketamine is a dissociative anesthetic, but that's not all. If we take the phenomenology to that, talking about disembodiment, complex and elementary imagery, blissful states, and changed meanings of percepts, then ketamine is a dissociative anesthetic that, when applied in sub-anesthetic doses with the right mindset, setting, and preparation, can lead to a psychedelic experience. The old definition is not wrong, it's just incomplete. And integrating both aspects, we just need to have the necessary cognitive flexibility to adapt to this new terminology. Therefore, we are proposing that ketamine is an atypical psychedelic, maybe as atypical as an anesthesiologist in a psychotherapy practice. Now, standardization of ketamine, that's the title of my talk. We have standardized this treatment in a way that we adapt it when the patient needs it. There are patients with PTSD that won't fit in this kind of therapy. They need a lot more of preparation, a lot more of integration, a lot more of trust building with the therapist. So yes, this is a very standardized way of approach, but it's just a base to modulate and adapt it depending on the patient's needs. It's not a one-size-fits-all. If you take a look at ketamine clinics, and I'm saying ketamine clinics for a reason, you will see all different sorts of settings, everything away from standardization. So one more esoteric, one more white-coated and very, very neat. And others where you see patients just lying there, sitting there, doing stuff on their phones, not really going into their experience. They're just being laid on several beds beside each other, and when this drop finished, when the infusion finished, they pack the things, therapist comes and say, okay, bye-bye, and the next one arrives. So this is a very profitable system, but not for the patient. Why don't we lean on what we have learned from the trials with classic psychedelics and use this substance with the same respect and do psychedelic augmented therapy with the tools that we have at hand? Now, a lot of people probably have seen this, this headline from the New York Times. The psychedelic revolution is coming. Psychiatry may never be the same. And it doesn't stop at the New York Times. Psychedelic psychiatry, a revolution, a set of transformation of mental health. And they may treat the post-COVID mental health crisis. Can psychedelic drugs solve our mental health crisis? Is it a game changer? Is it going to revolutionize it? Well, I mean, it's only human to think or to say, if only I had this, then I would be able to treat every kind of problem. If only we had access to classic psychedelics, we could treat all these patients. And what happens then? What happens when we have access to that? Are we going to say, if only we have access to that psilocybin derivative that is better for some and it seems to work a little bit better, and what then? If only we had access to a non-psychedelic serotonergic substance that would... So you get the pattern, you get what I'm saying here. We are forgetting to investigate and use the tools that we have at hand to treat the patients that really need it, because we're trying to say, okay, that what I don't have is going to be the changer, be the game changer, the revolution. And for those who don't know, OVID, the name of the clinic, the name of the company, comes from the name of the author of the Metamorphosis. And so much for one patient as for the whole field of psychedelics. This needs time. These cannot be accelerated. This needs for the proper care, and you cannot pull a butterfly out of its cocoon. It's the struggle of the butterfly going out of there that creates this beautiful thing. We at the OVID clinics believe that the therapeutic process starts upon first contact, when we get an email, when we get a call. That's when therapy starts. We are a psychedelic-augmented psychotherapy clinic currently using and further developing the application of ketamine to induce a psychedelic experience. And in 2022, we are going to start using, if everything goes well, psilocybin. We are confident that the best effects will be reached by combining SAND. That's an acronym, more to that in a moment. And we work with the 5 therapeutic principles that I have mentioned before, with an integrative psychotherapeutic approach that is not based in only psychoanalytics or only cognitive-based schools of thought. And we are looking forward to the implementation of other psychedelic drugs, not as a substitute for ketamine, but as a complement to the available tools. Now, what is SAND. We refer to SAND and the combination and implementation of this as the serotonergic psychedelics, atypical psychedelics, non-pharmacological forms of induction, and digital tools and interventions. And this combination, we believe, that will be the future of treating mental health. I want to thank the people working at the Mind Foundation. I want to thank the people working day and night at the OVID health systems to well, bring us where we are today. And I included a photo of the giants and this dwarf just standing beside them, which I'm very, very thankful to Professor Gerd Gründer, to Andrea Jungabele und Hendrik Jungabele for all the support they have done and, well, all the work that they have done through years and years and years to get us there where we're at, because it's because of the work of these giants that I am able to look further. And of course, thank you all for creating this wonderful situation, wonderful place in this museum, and great public. Thank you very much.
And while that other microphone goes around, I actually wanted to start it off. You mentioned compassionate use. Are Swiss people soon going to have to stop saying that we're the only ones who have compassionate use?
If we do everything right.
Yeah. So it's maybe coming. I just didn't. You threw that out there, and I wanted to come back to it and get a clear answer. It's maybe coming. Wow, that's exciting. Okay. Next question. We do want to know more, but you don't have to say if you don't want to.
Next year.
Hi. Hello. Thanks for your presentation. It's very inspiring. I have a few questions. First, I wanted to ask you, what do you think, you mentioned it briefly, but how do you think the patenting and commercialization of esketamine might impact the kind of treatment you're offering? Because there's maybe some confusion in the general public, and from what I understood, this doesn't work as well as the racemic mixture that you're using.
Well, the patenting and this Spravato approach is a different approach than ketamine-assisted psychotherapy. It's a pharmacological approach, and it does work for some. Otherwise, they wouldn't have gotten a patent. But the costs and the regulation of these costs are something that will show in the next years, because Spravato is very, very expensive, and it doesn't seem to have a long-lasting effect the same way that you would have when you actually do psychotherapy augmented through a pharmacon. So it's just a pharmacological approach, the same that you would have with an IV application without any integration.
So you think the lesser effectiveness is only due to the fact that it's only pharmacological and not because of the molecular structure that differs?
Absolutely.
All right. Then I wanted to ask a painful question, but what's the financial cost of this treatment at OVID Clinic, and can insurances or the state support the cost?
That is indeed a painful question. Well, for our patients, and this is why we screen them also so well psychiatrically. Yes, because we only want to have patients that will benefit from the therapy, where the potential to get better is there. And the cost, depending on the approach, depending on the individual, goes around 3,500 and 4,000 euro, which, when you take a look at this whole concept, is not as high as you would think compared to normal psychotherapy. And if it stays like we think it does and helps to limit the amount of psychotherapy hours afterwards, then this would be something beneficial both for insurances and for the patient. In terms of insurances, there are private insurances that have already taken over all the costs of this concept. In Germany, at least, we are talking with the regulatory entities to make this accessible always and make it more cost efficient. Other than that, yes, it's mostly privately paid.
Thanks. Last, very quick question. Which software did you use for your presentation?
Oh, that's PowerPoint.
Oh, okay. Amazing.
Here, thank you for your presentation in the middle. So I also have a pharmacological question about the R-ketamine. It always says that R-ketamine has more psychological adverse effects, and I wondered that this might be helpful in a therapeutic setting to work with the patients. Are there any trials about R-ketamine?
There are pharmacological trials of R-ketamine. There are some studies about the effects of isolated R-ketamine. I don't know exactly if they are more beneficial, but the esketamine approach, and again, this is not a thing about effects, it's more a thing about patenting, a thing about pharmaceutical companies. Esketamine is already being used not as a nasal spray, but as an IV medication in emergency medicine, where I have used it several times, also in pregnant women, because it's the anesthetic of choice for emergencies, because the respiratory distress is non-existent, and it is safer even for the fetus. Now, why I'm saying this, esketamine is being implemented like that because there was this idea that the racemic mixture used to cause horror trips. Yeah. Of course, if you apply this highly psychedelic substance after a car crash, after a car accident, I can imagine they will have a horror trip. So in emergencies, you combine this with a benzodiazepine so that you create a loss of memory intentionally, just using ketamine as an anesthetic. And that's where the whole discourse of this adverse effects of the R part of the ketamine come from, as far as I know.
And you use the Racemat in your IV therapy?
Yes. Yes, we use the 50-50 mixer.
Thank you.
Hello, just there. Thanks for your impressive presentation and the work you're doing. I was asking a question like more light. The set and setting you built in your clinic, which I find totally amazing. Is this inspired other field of medicine? I mean, not only psychiatry, but like hospital in other in other field. Are they inspired by this? Because like if I take my experiences in France, I always find that the hospital is a place that is really not adapted to heal people, and not only in psychedelic way, but in all other way of medicine.
So the question would be:
did it inspire? Sorry, other hospital or clinic in other field of medicine?
Up until now, I don't know of any clinic that is inspired to change their facilities to create a more warm environment, but I might be wrong. I think this is a special thing that is happening in the psychiatric field, because we are learning that the setting that we provide, be it at a monastery at Mount Rigi or a warm room where you can change and dim the lights, make it feel safe, make it feel as less sterile as possible. That's something that we have to start creating, and of course we have inspiration, and of course we have regulations and costs that we have to take a look at. So they all play a role.
Thank you very much.
Hi, thanks for the talk. I have a question for the integration therapy. Like, how often does it happen that your patients cannot recollect or cannot articulate the experiences they've been through?
Not that often, because we take the dosage and adapt it to the body weight, to that what we have learned from research in the field of the antidepressant effects of ketamine, and is a 0.5 milligram per kilogram body weight in given in a 40 minutes time lapse. And sometimes we have to adapt this. Yeah, sometimes the effects are too little, and they say, well, I didn't really felt like I was having a strong experience. So we go higher the next session, and this is why we have 5 sessions, and we can adapt throughout this process what works best for the patient. Also, on the other way, going lower on the dose depending on the metabolism and the experience that the patient has. It also depends a lot on their cognitive abilities to what are they making sense of, how deep this experience is being understood. And when you go higher on higher doses, and I know this from anesthesia and my work at the hospital, then yeah, people forget. People just know about the beginning and about the end, if lucky.
And separate question, how do you compare this? This is more vague, but how do you compare this to psilocybin-assisted therapy? Would you think that, as Professor Zolino was proposing, it's a similar mechanism where you open up more choices or behavioral patterns, or would you say it's any altered state coupled with therapy helps, or is there some fundamental difference?
Simple answer: we don't know. But I do believe that this setting and the choice of environment and the substance that you are administering does have the effects in the same way we give it every 7 days, because the data seems to show that the ketamine effects, the pharmacological effects, go down after 7 days. So different than in psilocybin, where you have this larger window of opportunity for neuroplasticity, to learn new behaviors, to make sense of things differently. We need to give these doses again and again to keep this window of opportunity open for people to change, to expand, if you wish.
Thanks.
Thank you for your talk. This may be a fairly naive question because I'm not terribly familiar with the compounds involved. You have described ketamine as a dissociative. Are you aware, and I'm not sure that you are, this may not be a relevant question, are there any similarities pharmacologically that you know of between ketamine and Salvadoran A, which is the active ingredient of Salvia divinorum?
With Salvia being on dissociative as well, but I do not know if that's the same mechanism of action. There is a similar mechanism of action with laughing gas used in anesthesia in dentists, for example. That's the same kind of dissociation through the NMDA receptor antagonism. And scopolamine seems to have similar properties as well.
So that's where some of the anesthetic activity comes from.
Right. Well, basically both the anesthetic and the psychedelic thing. Like you learned today in the morning, it's a thing about dosage. If you give too much of one substance, then you create unconsciousness. If you manage to find that sweet spot, then you might create expansion and a psychedelic experience. Not always the same as a serotonergic substance. The same case you would have with MDMA. MDMA can also be called an atypical psychedelic because it doesn't act the same as a serotonergic substance, but creates similar experiences.
Okay. I also remember that there was a time when PCP was fairly widely abused in the U.S. We no longer call PCP, we call it ketamine. Do you have any idea how that came about, or?
Well, you don't call PCP ketamine, you call ketamine ketamine. It's a derivative, and if you want to take a comparison chemically, comparing DMT to psilocybin and to 5-MeO-DMT chemically are not that differently, but create completely different effects. So it's not the same.
Oh, okay. Well, thank you very much.
If I may jump in on the salvinorin A question, I believe it's a kappa opioid agonist, so that's yet another receptor system that can cause hallucinatory effects.
Thank you.
So thank you for a great presentation. I just had a question about the inclusion and exclusion criteria, especially the psychological ones for ketamine-enhanced psychotherapy.
Well, what we try to do is provide this therapy for people that have gone through kind of treatments before. So it doesn't have to be treatment-resistant depression, but it also can be major depression. We try to screen out the people that have a will to work with the therapists and are not expecting for the substance to make the work for them. You know, as I was saying before, this is a vehicle. You can take a look at it and say, well, this is a nice vehicle, and then not do anything with it, or hop in and then go further than you would do walking. So those would be some of the inclusion criteria. Exclusion criteria go into the side effects of ketamine, like an increase of blood pressure and heart rate. We would screen out at the moment the participants, the subjects that have difficult to manage hypertension, coronary heart diseases, or some vascular malformations in the brain. So this is for them to have a safe experience. We cannot guarantee that someone with bad blood pressure will have something of a heart attack or a stroke while under the therapy, which we don't want.
And how about a family history for psychosis or, for example, a comorbidity with personality disorders?
Mm-hmm. So personality disorders are taken on a one-to-one case. So we take a look at it. I'm saying our psychiatrist, our psychotherapist, they talk with the experts. We have several advisors in their field. We're talking about expanding the indications for substance use, where we would have an advisor that helps us to screen through these patients, and we wouldn't do it without his expertise. So yeah, that's one of the points. The other point on the histories of psychosis, as I mentioned before, ketamine doesn't have really a documented case of inducing psychosis after treatment. So we always are careful. We don't want to have a patient ketamine-induced psychosis. We don't want to be the first point in the statistics, but I think that taking care of how you approach the whole thing and not just throwing substances in one person also has a lot of value if someone will develop a psychosis or not. I don't know if there is documented cases of psychosis in the studies and the trials that have been done until now with psilocybin. Well, the other thing is that the trials are small numbered. There are not a lot of participants. The one in Charité in Mannheim with 144 patients. We will see if something happens there, but I do believe that setting can change the shift into a psychosis or not.
Thank you.
Back here, top back. Some people have asked questions that were answered for me. Thank you very much. A question about the dissociative disembodiment effects of ketamine. And in the context of depression, I can see why that could be helpful, because sometimes somebody just needs a break from themselves. But is it ever determined that this would not be appropriate? In other words, sometimes what somebody might need is to not be disconnected. And in actual fact, to be found a way to come into their body. So on those grounds, do you ever determine when somebody's not suitable for ketamine therapy?
Okay, if I understand the question correctly, let's say that getting more in touch with one's body would be beneficial. Then this kind of treatment would be beneficial mostly at the end of the experience, where the ketamine goes out of the system, the effect drops, and the body feeling and the embodiment of it comes back, so that you get this feeling of getting in touch with your body again.
Right. Right. And then I have another question. Has there been any research into the combination of ketamine with other psychedelics? And I say this because it has the propensity as a sort of amplifier and expander of spaces. It can go and explore the extent of another space on your behalf, whether you want it to or not. So, you could use ketamine in smaller amounts in conjunction with other psychedelics to really just expand and explore that space even further. Do you have any comment on that?
As far as I know, there is no study combining ketamine with other psychedelics. We are just beginning to get the license and this process of applications and getting the studies going with just one substance. Mixing substances might be interesting, but at the moment we want to pin down the effect of single substances.
Right, in particular MDMA and psilocybin.
That's another example. I think it was on Friday that someone was talking about the potential combination of MDMA and LSD.
Right.
But yeah, it's necessary to go step by step and find out.
Thank you.
Right here. Thank you for this interesting presentation. I have a question about, do you indicate ketamine in bipolar depression? Do you have results and the risk of induced mania or hypomania?
Right. There are results. There is an indication. Not everybody is excluded, but the rapid cycling bipolar disorder, that is exclusion criteria for ketamine-assisted treatment.
Thank you.
Any more questions?
Hi, Sergio. I have two questions. One is, are you tracking your patients after treatment, like periodically, 3 months, 6 months later, and to see how they are doing?
Yeah, so as you might remember from the presentation, there is a follow-up after 4 weeks. There is a follow-up after 6 months. And that is a must. That is something that we want to track by every one of them. And then there is the individual adaptation of a protocol. If the therapist says, I would like to see how it looks after 8 months and how it looks like after 12 months. Of course, not every patient is open to this, and you cannot reach all of them, but some are very happy to come back to the clinic and talk to us again. And we are also very happy to see them with a lower, at least psychometrically measured symptoms of depression.
So that is the conclusion, you have lower...
Yes.
Okay. And the other question is about this window of opportunity. You said that the effects go down after 7 days, so you have like a 7-day window of opportunity. And throughout these 7 days, I would imagine it's a curve going down. Is that right? Like the neuroplasticity is highest right after, or?
It's a good question. I can only talk about symptoms that might correlate with a neuroplasticity. Yeah, the symptoms go drastically down 1 day after infusion. The biggest effect that you can see on the symptoms of depression is after 72 hours, and then they start going up again. So if you want to correlate that to a state of flexible cognitive flexibility where you can work with, then the best moment to work with them would be after 2 days. Also good after one day, where you can reinforce that state where the patients say, "Oh, okay, this is me. I can be like this when I'm not depressed." Yeah, but it really goes drastically down and then increasingly high after 7 days. This is again symptomatic measurements and not measurements of neuroplasticity, which would, I think, be very difficult because we have one marker that might be correlated to that, and you would need to, take blood samples every day.
I see. Okay, thank you.
I also have a question. Hi. I have seen on your graph that the scale of anxiety is a little bit higher than for ketamine than for other psychedelics. And I wanted to ask you if you have experienced this, and if so, how do you usually treat anxiety during the trip?
Mm-hmm. So I don't. But the therapists in the room, they are trained to guide, and since they have had different contact points before they come to the substance-induced changed experience, they have built this trust where the therapist has a couple of methods that we have trained to lower the entry anxiety levels, the potential of developing anxiety within the treatment, and if it happens, then that's one of the reasons why we do IV ketamine, because we tell the patient, you can stop it. If you come to a point that you don't want to be in this experience anymore, and this is differently than when you take an intramuscular injection. When it's in, it's in. And this might be suitable for some, yeah, letting go of this control. But some others that are more anxious, more on that spectrum, might need this feeling, this subjective feeling of safety, of agency, to be able to say, I don't want anymore. And that is, of course, the last resource, the ripcord. But we haven't, until now, needed to stop therapy during a session.
Thank you.
I do have a question here. Yes, I would like to know where come your patients. Does they come from? Are they treated by psychiatrists or therapists? I imagine. And in this case, I would like to know how these patients and the therapist especially are involved also in this experience, because most of the psychotherapists has no experience with psychedelics. Mm-hmm. And it's very important, I imagine, for psychotherapists to know a little bit these effects, to follow correctly the patients before and afterwards.
Absolutely, and you're completely right. The information out there for the general psychotherapists is very little, so that we are working in a program to train people that want to direct patients to our treatment, so that they know what they are recommending for their patients and how to implement that in their long-term treatment. And what we do at the moment is that we talk before with the current therapist of the patient, and depending on how much change and how much happens within these substance-induced sessions, we talk in between sessions as well, and at the end of the therapy. Not a lot of cases at the moment of a therapist sending us patients. I think that will change. At the moment, the motivations comes from the patients, or the disappointment that they have not gone further after years of therapy, of regular therapy. So I think that the field is changing, and the more we talk about this openly, the more we show that this is not an approach where we want to keep your patients, but we want to provide this safe environment, safe room, and this kind of experience, and then in contact with a therapist, give them back, so to speak. Then the idea on how we work will become more public.
In this case, I have another question. If the patient has a very good relation with his therapist, would you like to invite the therapist in the therapy? I mean, during the session?
Yes.
Yeah. Is it important? Patients, they go through this experience with ketamine. They don't know always the anesthetist, or well, they may have seen them one or twice, but they don't know exactly these people in OVID clinic. Mm-hmm. And I think it's very important that patients has somebody that they know and they have a good relation with.
Well, I think this is an individual decision that the patients have to, well, at some point take the responsibility for it themselves. We are not just greeting the patients and at the same hour giving them ketamine, but they are having several points of connection with the psychotherapist, not the anesthesiologist, but with the psychotherapist, where they develop rapport and a therapeutic relationship. Of course, not as deep as someone in regular therapy for a long time, but sometimes it's not that. At least from the point where we are looking at it, is not always necessary. There will be patients that don't want to have the regular therapist in the room with them. There are patients that say, I only want to do it with my therapist. So we adapt, we are flexible, because this is a new concept that we are developing, and this is a new field, and we're not saying we have all the answers, we're not saying this is the only way to do it, this is only the way that we have done it before, and it has shown positive results.
Okay, that's all we have time for. Thank you again, Sergio, for showing us your clinic.